Welcome to the Human Capital Innovations Podcast, your go-to source for personal, professional, and organizational growth and development. We hope you tune in often for all things people management, organizational development and change, organizational leadership, and social impact related. Maximize your personal and organizational potential with Human Capital Innovations Podcast. Welcome to the Human Capital Innovations Podcast. In this HCI podcast episode, HCI Research Associate Dr. Leandra Hernandez and her colleagues continue their weekly COVID-19 Convo via Facebook Live to discuss all things COVID-19 related.
Well, we've been sort of waiting for Andy to come back to talk about this issue of healthcare rationing, but it doesn't look like we're going to get Andy back. And a story dropped in the New Yorker this week that talks about how going back to the aughts, going back to like 2005, 2010, they were already preparing for pandemics, and they were already aware that there would be these critical shortages of ventilators, and there were already plans for how do you allocate resources in a low resource environment. And of course, the concept of triage goes back to the Napoleonic Wars, right? We've had that, and that happens every time there's a mass casualty event. But this was very specifically about how you're going to allocate ventilators to people who need them. And it's interesting. Some of them, kind of went toward a lottery, and some states went toward, we're going to look at, all of the factors of, whether someone can recover. And then there were some who had sort of exclusionary aspects. So for Alabama, one of their qualifications was if a person is severely mentally disabled, they don't get a ventilator.
Yeah.
Wow. I've been doing a lot of reading for just in case that comes up here locally. And like those differential models. So the one way they've looked at it is doing what's called an MSOFA score, which is sequential organ failure assessment. And so that's supposed to help them determine how likely the ventilator would be to pull you through this.
Right.
But then people talk about also another model you could use is long-term survival. Mm-hmm. But the problem with long-term, long-term prognosis. It depends how you frame it. Because some models would say things like, if people tie on their sequential organ failure score, then what do we do? Then we should look at long-term, and there's some models that said long-term frailty. Mm-hmm. And then there were people, myself included, that were like, oh, you cannot term it like that, because there are many conditions I can think of, like cystic fibrosis, and this example comes to mind as something that could indeed make you frail, but doesn't necessarily mean that your prognosis long-term, if you're 15 with CF, like you have a pretty good long-term prognosis right now, but you are probably frail. And so there's been a lot of debate about the very minute semantics of how we frame that. The best ones I've seen, if there's a tie in the short-term prognosis, then say long-term prognosis only factors in if you have some sort of comorbidity that limits your life to less than a year after this incident, which you could say is still rather short term. But then other things I've seen have been debates about, should we take age into account? I've seen so many debates that are like, well, if you have an 80-year-old whose long-term and short-term prognosis is very good, then there's no reason to take age into account. Like the age should be like it kind of takes care of itself. Like if they have comorbidities, that will show up on those two short and long-term prognostic indicators. But then other people are citing studies that show regression analyses, which are very powerful means of determining causality, like about the best we have, saying that other factors accounted for. Age seems to be an indicator to this, and we don't know why. So that including age isn't ageist, it's a clinical factor. Mm-hmm. And I don't know how to respond to that.
So in public health, we use these things called DALYs, disability adjusted life years, and then factors in like the amount of time people are living with some kind of morbidity, right? Some kind of like thing that impacts their like daily ability to function, not necessarily like the way we think of disability, like to like for mobility's sake, but just in general. So like, I wonder if they're taking into account any of those. But then like looking at it from an age perspective, not to be ageist, as somebody who is like rapidly becoming in that age group, like aging into the age group where you're like, no, but like, let's think about it. But it's like one of those things that health insurance companies make that decision all the time based on age. Like, are we going to see, and I hate this term, especially when we're talking about health, and I don't agree with it at all, but like that return on investment, right? Like, the amount of money that we're putting into saving this person's life or prolonging this person's life, how much time do they have left? And would they have left on like a normal life expectancy curve? Which again, like all of this feels like it's like very uncomfortable to think about it this way, but it's like one of those things that age does play into it a bit. And then if you're looking at the other underlying chronic conditions, which I think is why the age plays into it. Because like, from the aging process that we all start the moment we're born, we're all dying, right? Like
I say that all the time to my students. We're all dying every day.
Right? Like, from the moment you're born, you start dying. So it's like, fine. I mean, it's really depressing, but it's one of those things that, you know, you're living longer, but you're having more years that you're living sicker or like less healthy, right? So like women live, traditionally speaking, longer, but we're living longer amounts of time unhealthily, or like with compromised or reduced health, right? So yeah, because like women's life expectancy is always longer than men's. So it's like one of these things. Is it something that the body then could cope with after recovery from something like this?
I love that DALY thing. I hadn't heard of that.
Yeah. Oh, it's huge in public health. DALY.
Yeah. Oh, I wrote it down.
Yeah. Disability adjusted life years.
No, there's apparently it's just one study, and like back from my days as a statistician, you know, one study is only worth so much, but there is apparently one study that uses that regression analysis that said all other comorbidities accounted for, age just seems to be a factor in this. And so there's been a lot of debates. Right. But I think, if I had to weigh in on it, I'd probably say that's one study. We don't have a lot of data. We are accounting for age by allowing for comorbidities. And like, if you have a 70-year-old that is just for whatever reason healthier than a 30-year-old, then I don't think we say like, well, the 70-year-old age marker counts. Like, I think we should look at it objectively of health and life years, I guess.
Yeah.
Well, there's also been, some suggestion that men are more susceptible. Do we start saying, well, between a man and a woman on a ventilator, right? It's another question. One is the question of cost of resources, but that question of cost, when it's mapped onto, who's going to get the resources, that, if you take this person off a ventilator, they will die. But if you don't take them off, this other person loses their chance.
Yeah.
Mm-hmm. Well, and the blanket DNRs, I just keep thinking about, Pamela, the discussion you had about blanket DNRs, and that you and I both saw, I hope I'm not telling tales out of school, but like there was an MD that was like, that would never happen in America. And that scares me if we get to a resource allocation situation, that there would be violent responses if we have doctors that don't think things could get like that here. And as like somebody who studies like social factors of health, I'm sure you guys would all agree, like I feel like if there's a party that's responsible for resource allocation getting to a crisis standard, it's not the healthcare practitioners, it's not the ethicists. They're trying to do what they can with the situation that I think was handled poorly from an administrative level. but I don't think that people will see it that way on the ground, or I worry.
I wonder, I mean, it's going back to the communication side of things. I mean, all of this feels very, just to me, just talking about it feels very dystopian, but to try to be a little bit more positive, I'm thinking about how people, I wonder as this progresses, whether people will voluntarily make some of those choices. Like I wonder
people are
with voluntary DNRs or people making more living wills and stuff, and kind of
people absolutely are,
making care plans, and that might simplify some of this. I mean, not that we're talking about crisis situations where it obviously goes beyond the ability to handle it all through voluntary decision making, but I mean, I think a lot of times when people are given all of the information about what resuscitation looks like and what all of these things working on a ventilator means, especially for people who are, older, like 80 plus, 90 plus, they might have some input. They might want to have some input into that process.
I think it's something, so I have a medical directive and like a living will and all of that. Just some full disclosure, my father passed like 3 years ago. So like very much saw firsthand like those decisions that had to be made, and he had all of that stuff in place. And then after he died, it was like, oh, right, I should do that too. And it's like a very surreal and uncomfortable thing to have to do, but I'm glad that I did it. And I made them like when I was healthy and I was able to think about them. But it's like so many things go into it. It's like, it's even like the decision, like if you're experiencing pain, do you want them to withhold like aspirin or morphine or any kind of like painkiller? Right. So it's like, it really is a very standardized form. Like obviously it's like a legal form. Yeah. And there's like so many different parts of it that people just don't consider. Yeah. But I think it's like kind of one of those things that, I mean, you can't force anybody to do anything. I'm certainly not advocating for like authoritarian kind of movements towards this, but it's like one of those things that I don't know should be included in. I don't know, college or like retirements that like when you're setting those kinds of things up, there needs to, generally in America, there needs to be this like approach towards how do we educate people on like all of these other life factors that nobody ever talks about, right? Because they're uncomfortable or because people don't have them. And it's like very much an intergenerational thing. Like I only have it because my dad had it. And I only found out about it and thought about needing to do it because of this. And like it had come up in like my education because I'm in public health. But I was like, that's a problem for like later. And like healthcare decision making, humans are not rational actors, because if we were, we would make very different decisions. And we're really, really bad about thinking about our future selves. And it's like always this like, because you're constantly playing against that counterfactual of like, well, what if it happens? Well, what if it doesn't? And like this belief of like, I've always been healthy, so we'll always continue to be healthy, which is of course not ever going to be the case.
Right. And very often people don't understand what it means to choose, for example, no extraordinary measures or these levels of refusing treatment. I remember many years ago, I was quite young, and my good friend's grandmother, was deep in Alzheimer's and not doing well and in a care home and not very happy about it. And so my friend's mother had said, okay, we're refusing treatment. Well, then suddenly her grandmother gets a terrible urinary tract infection and is in a lot of pain, a lot of discomfort, a lot of misery. But when it's a matter of just like, oh, I could just give you an antibiotic and that would go away. Like that is not how she pictured the refusal of heroic measures. Right. And so I was really careful about it.
I was actually going to mention, I had a friend, I'll just say, I don't want to give away the relationship too much, but where this happened, they got a UTI and then they also got colitis and they didn't have any advanced orders, but they decided to refuse antibiotics in that moment. And it was really distressing for everyone. And in the end, though, like I did some reading about it and how that is not a part of no extraordinary measures that we think about, but it is a part of it. And, you know, it just actually really got to me because as you know, Pamela, like my whole forthcoming book is about the fact that if we sacrifice everything to just stay alive, then we've probably lost an essential part of our personhood. And yet here I was watching this friend make this decision, and I was like, let me at the ethicist. Like, I want to talk to them. She needs to have antibiotics. Like, but she was living the truth that I've spent 10 years writing, especially because with writing about the Victorian era, I write about bacterial infections. Like, but I never seen it played out. And so, like, I was able eventually to find that to be a very brave thing. It's a little bit different than your friend because she did decide in that moment, no, I don't want antibiotics. But it's just, you know, that just spoke to me that, like, we really don't think about infectious disease in America as often as we think about things like cancers and autoimmune disorders.
Right. We will now.
I always say that if I was going to go back and do a second PhD, which will never happen, I think there's something distinctly American in our, like, probably it comes from like our legacy of colonialism, where we have used virus and pathogens and ill health as a way to dominate and subjugate other like native populations. And I think that's something that's really unique.
I'm writing an article about that right now for American literature, actually.
Yeah, so I think there's that, whereas like we see like in Europe, they have the common experiences of like the bubonic plague and all of that like have drawn together like the social contract a bit more tightly. But like American are like individual, like rugged individualism, right? Like the Marlboro Man and all of that is just like it's just not part of our culture. And
or we've forgotten a good bit of our culture, right? Because I'm down in the South where yellow fever like massacred tons of Europeans.
I'm writing about that right now for American literature, which I guess I've just like networked really well recently with Americanists who focus on germ theory. I'm currently debating how to make this work for my CV. Anyway, regardless, that's exactly what I'm writing about, is like comparing the British versus the American uses of germ theory and reception of germ theory. And my conclusion has been that the two cultures are united through what I'm calling necrocapitalism, like a way of exploiting human labor that is intimately wrapped up with microbial pathogens pathway through our environment. But that the American individualism gave it a specific brand of like, I don't know, that there's like a little bit more of a loss of community than you even see with like colonial Britain. Current struggle is I thought it was a 9,000 word article, and I realized that it was a 3,000 word article when I was 3,000 words into a 9,000 word article. So anyway.
It's going to be another article. It's going to find another time.
Yeah.
It's a series. It's a 3-part series. There was a really great article in Jacobin maybe 2 weeks ago that talked about, so disclaimer for anyone who's watching, it's a socialist democratic publication, so definitely there's some bias there, but they were talking about the foundation of the NHS in Britain and how like this is a unique moment in American history where we can learn from that, because the two kind of backgrounds, like cultural, socio-political backgrounds, are really similar. Because with the bombing, like in World War II, they didn't know where bombs were going to fall, who was going to be affected. And so everyone was like at equal risk, very much the same way we're seeing with the virus right now, where like it's hitting wealthy people and lower socioeconomic like people with lower socioeconomic status and all of this. And it's like this unique moment that we have, like if we could come together and just be like, well, we're all humans, we're all Americans, like this could lead to this formation is like complete and total revolution of the American insurance system.
And yet I fear that the very unequal death tolls in different communities is going to militate against that to somewhat. I mean,
structural racism and healthcare redlining has always existed, and
yes,
SIM is working effectively and efficiently, but not the way you want it to.
It's interesting. I mean, you were saying that, you know, we don't think of infectious disease as the threat, but, you know, I mean, I remember the AIDS epidemic, and it's a different kind of infectious disease. And here's a perfect example of something that was associated with particular communities and therefore considered not to rise to the level of national concern by then President Reagan. But also because it wasn't sudden, right? It was devastating, but it wasn't something that you got sick, 2 weeks after you'd been exposed and then you were dead within 2 weeks, right? It was this thing that unfolded, which of course made it much more dangerous because there were so many opportunities to spread it.
Yeah.
But, there was no kind of national mobilization for a long time.
Right.
In the same way. And I think that, it's interesting that I think we often kind of tend to forget AIDS as a major epidemic, in part because it doesn't have that signature of people getting sick and dying in very short periods of time. Right?
I wasn't able to share this, was it last week that I couldn't get my mic to work? But one of my favorite articles ever is by Claire Hooker and a few other people. Then she says that, like, in a weird way, when we label something an epidemic, we're labeling it something that we want to mobilize public health activity towards. But when we label something endemic, like, you could make the argument that particularly in the 80s, 90s, HIV was considered like endemic to the homosexual population, that enables us to just ignore it. It's sort of a justification for saying, like, well, that group just has this infection. But I was going to ask Mary Beck to weigh in on this because her dissertation was on HIV. So
oh, wow.
I'm sure you have a lot of thoughts.
One of these things that we've always seen is, like, whenever there's a marginalized community, and this time it's like around like the religious right being like, oh, well, like the LGBT community is something we definitely want to keep suppressed, and like they're othering them because of their like social factors and like their social behaviors. I think that's another way, as long as you can other them and you only see the numbers occurring kind of like endemically, like Kari was saying, in these communities, it's a way of being like, well, we're safe because we're good and we're moral, right? So there's always that encoding of morality that happens. And I think that's obviously something that's like particularly different with this virus because it's spreading wildly and widely, and it's not keeping up with those like social norms and things like that. So yeah, I think it's wherever you can demonize somebody, you will. And I think we are seeing it like a little bit with the coronavirus, like the demonizing and like othering of Asian Americans or Asian individuals, obviously, right? But I always say, like, the thing that has to happen for somebody to care about a public health issue is that it has to affect them. And it's really easy when it's not happening in your communities to be like, well, I'm safe because I'm not part of those communities. And we don't have that protection with this. And then, like, also particular to HIV, the infectiousness factor, the R naught, is really low. Like, it's HIV is not actually that very infectious level of disease, but the R naught factor with COVID-19 is like, it's really high. So we're seeing more and more people being affected and things like that. So
yeah,
I remember when we didn't know what the R naught for AIDS was when we were, in the early days of the disease. That's true. There was no idea of how rapidly it was spreading because there was a long latency period. But
and the progression of the disease in a body also depends, like, how healthy a person was, what their CD4 count, the viral load, all of that was. And if there are some like long-term survivors that they're studying now that were infected with HIV like back in the early 90s, like late 80s, early 90s, and before there was medication, and their bodies were just resilient, and they don't know why that is, if there was something about their genetic makeup that helped or healthier, but like why they survived and why other people didn't.
Well, I address this a bit in my book, like, because I deal with a different, Mary Beck, you wouldn't know this, Pamela and Chen do, but I deal with a different pathogen in each chapter. And one thing I teach my students a lot is like the biological manifestation of a pathogen absolutely impacts how society deals with it. So for instance, like TB is similar to HIV. It's a very weak pathogen. You kind of have to be immunocompromised to really get it easily. It has a super long latency period. And so even though the bacteria for it was discovered in the 1880s, people were still debating into the 1920s if it was like maybe still genetic. Like,
Yeah.
and so weirdly, like germ theory didn't cling to it the way it did with everything else. Whereas like you take the measles or smallpox, that it's just, or Black Plague is one I usually use as an example.
Mhm.
Germ theory wasn't the first idea of contagion. I mean, like you're living through the Black Plague and it's just really obvious, you know, that like you hang out with Sam and Sam has oozing buboes and then like a day later you get the, like, it's just obvious. And I think sometimes those cultural mythos and like marginalizing prejudices can spring up over diseases that are less visually obvious to us, like HIV and TB, because we're trying to fill in that gap.
HIV was so associated with Kaposi sarcoma in the early days. It was like that was the sign, was, you know, that was like the sign of the leper was the visible sarcomas on the face and on the torso.
I didn't know that.
Yeah. That's how with the MMWR report from the CDC, they were like, we're seeing this like resurgence of this like really, really rare cancer at prevalence levels that we had never seen before. And that's what then led them to do the background research into like, what is the underlying health cause here? It's like, we don't see Kaposi sarcoma. They're super rare. Yeah. I was having this really interesting discussion with one of my students after class yesterday. And she's like, you know, I'm like thinking about like the recovery and like when we're going to be able to like resume some kind of like normal life. And she's like, you know, like part of me wonders like, in this time that we're waiting for a vaccine, is that going to happen? Like, what if this virus isn't receptive to vaccines? Like, what if we can't make a vaccine for it? Like we can't with HIV and stuff like that. She's like, you know, but if you've had it and we can then have herd immunity and if you can't be reinfected, like, is it better than just like go out and get the virus and then you'll be safe and then we can kind of return back to normal? And I was like, it reminded me of these things that used to happen like when I was a child.
The chickenpox parties?
The chickenpox, right? Like, because we didn't, I was like, yeah, you know, like when I was a kid, we didn't have vaccine for the chickenpox. So like whenever one kid was sick, like the parents would be like, go play with these kids. Like, and it was like, yeah, so it's like an interesting thing. It's like, you know, we don't know if the virus works that way or things like that yet. So like, no. And also don't want to overwhelm the healthcare system, but like, it is interesting that we're seeing these like kind of narratives, like, well, what if a vaccine doesn't work or can't be developed? You know?
And of course, your parents didn't think, oh, I'm giving my kid shingles in her old age when they did that, right?
Right. They're like, we're actually preventing, you know, some.
Right.
Yeah.
Right. I mean, the problem with that with this whole notion of herd immunity is, first of all, we don't know how much immunity it grants this disease. And secondly, the sequelae that are starting to emerge from this disease are really
scary. I saw that
scary.
thing you posted the other day. I read that.
Yeah, we seem to be seeing, I mean, it's very preliminary because we're only now starting to see the survivors, but, you know, we were worried about ventilators. Now we have to worry about dialysis because so many people have kidney failure from this.
Yeah.
Okay, I did not see that in this article.
So yeah, so now there's a shortage of dialysis supplies, and this is emerging as a serious, you know, and it's again because we know so little, we don't know like who gets these kinds of sequelae, what kinds of things lead you to get these, and plenty of people who rode this out at home and survived are going to find out over the next few months whether they're going to start to have heart issues or kidney issues or liver issues or brain issues. People are reporting cognitive stuff.
Yeah. And we also don't have enough tests to know, like, we still don't have enough diagnostic tests, and we don't have enough serologic tests to know who has the antibodies to know if they've had it and just been asymptomatic or like low level sick. So it's like, yeah. I don't know.
Is there a precedent, Mary Beck, for like, because I was reading some of that stuff, and I mean, we don't have data. We just have anecdotes, and we all know that there can be issues with self-report anecdote things. And so just reading through these, I mean, I just kept wondering, and Mary Beck, you would be, I think, the person who might know the most. Is there a precedent for coronaviruses to cause things like cognitive, long-term cognitive and organ impacts, or do we know? That just seems very foreign to me.
Yeah, I don't know. I mean, like, we could look back at like the SARS and the MERS data and see long-term, but like, again, those are only like a few years old. So like, we know like the immediate effects and like, I guess the short to maybe intermediate term effects, but like we don't actually know like the long-term effects of any of things, like, or even things like the Zika virus, right? Like we don't know the actual long-term until people have lived long enough, have recovered and like live long enough for us to follow them up over time. So I imagine we'll see like a lot of funding for like cohort studies and things like that. It'll be really interesting, like people who are diagnosed and then either were staying at home or got treatment in a hospital, and then people who were exposed and then obviously developed symptoms and then didn't go to the hospital because they were just like, oh, it's like a cold, or it's like, I just don't feel.
Or they couldn't get into the hospital. And hospital said, stay home, we can't test you, which has happened to me.
So, and like there might be different outcomes, long-term, short-term outcomes for people who had more severe cases and people who had less severe cases. And it's like one of those things that like we know what we don't know. We don't know it until enough time has passed, and there's just really like there's nothing we can do.
This is a Rumsfeld moment. There are known knowns, there are unknown unknowns, unknown knowns.
So it's like one of the things I don't understand, but it's like if the data doesn't exist, the data doesn't exist, and
I know.
You can't.
And we're not used to that in America. Like we're just, especially, I don't know America, but like our internet culture. Like I'm used to being able to Google, like, are there day owls? Like I Google everything I want. There's no unknowns. And so to suddenly be entered into a world where we can't just like have the answer at our fingertips, I think is very different for people.
And I think like,
and unfortunately people are finding answers at their fingertips which are not the right ones. I'm sorry, Mary Beth.
No, I was gonna say, like, it's interesting, like we know what we know and then we know what we don't know, and I can take comfort in that, but the whole wide part of the middle, like of the we think we know this but we're not sure, that's the most uncomfortable place to live. Like the virus brought in on your shoes, it can like spread 16 feet and you're like, but what? So like all of this, like we think we know, but is the most terrifying.
Right.
I wanted to make sure we have one comment in the chat from my lovely husband, who is one of our devoted fans and watches every week. Something I've noticed is more of a laser focus of how many things we touch every minute of every day that others have touched. I'm going to let everyone else answer this because he and I are the only people we have to talk to most of the day. So he probably doesn't want to hear from me anymore.
Right.
Jen,
it's making me think of Tina Young Choi has an article, I think it was in ELH or Novel or something, I can't remember. It's about contagion in Bleak House. And she's talking about the way that like just thinking about contagion elevates the importance of the everyday or the mundane. You know, that once contagion can spread through all of these different vectors, then suddenly everything could be important, right? Like, was it the pen that you signed with at the store? Was it the, you know, like doorknobs, the railings, the mail? Suddenly all of these, like the minutia of everyday life comes into hyper focus. And it's sort of, it's making me, I'm definitely feeling that. And I'm feeling a little bit of a level of like interpretive overstimulation or something. It could be important. Then how do I know what I'm supposed to pay attention to? And
right, like all of those discussions about, you know, food and groceries and takeout and is it safe and is it not safe? And my neighborhood board is alive with people commenting on the people who are working in the grocery store, because we still have people working without masks and gloves in the deli section, for example. So people are getting their lunch meat, and then or not getting their lunch meat, and then making that assessment. But yeah, absolutely. And of course, you know, this is a cliche now, but I am hyper aware of how I'm always touching my face. especially in allergy season. It's like just constant.
Right. And now that you said it, I feel like I need to touch my face. I have 2 cats and a dog, and they're all over the place. There's cat hair on my face all the time.
Oh my God. And one of my cats basically is a dog. Like he rolls in the dirt and then comes in and rolls on my bed. I'm like,
no,
dude, you're supposed to.
That's just rude.
That's rude. Yeah.
I think there's like a couple of things. I think so much of the language that we use to talk about health is encoded in like things that are clean versus unclean, right? Mm-hmm. There's this very much like thing like, well, cleanliness is next to godliness.
Yeah.
So we're like this idea that like, if we can clean our way out of it, which I understand because people, there's so much unknown that people want to be able to do something to help, right? So just cleaning of groceries and products that come into the house from the outside, it makes sense. It makes people feel better. And I'm one of those people, like, if it makes you feel better, do it. Unless it's like actually contraindicated, like go for it. But I think there's this idea of like, well, if I clean well enough, I won't get it. And that proves that I'm good somehow. Right.
Right.
That's so Victorian.
The virtuous housewife.
So there's things like that. And then there's this really great article by Elliot Frieden that talks about the difference between disease versus illness. So like disease is like the pathogen that you have. And then illness is like your subjective interpretation of it. And I think people don't want to make or are concerned about like the cognitive dissonance that it would take to move from that. Like, what does it mean if I am a person that has COVID-19, right?
Right.
How do I feel about it? How do I now feel about myself? How are other people going to feel about me as somebody who has been diagnosed? Like,
how do I feel about infecting my partner?
Yeah. Or it's like, and you just think about your diagnosis like very differently. Like when like when I'm out and about and I'm coughing and I'm like, oh, I just like, it's just allergies. It's just something like that. Right. But if I was to go and have a doctor be like, no, Mary Beck, you have a diagnosis of like the flu or something like that, I would then feel very differently and it would affect my behaviors, right? So I think there's also, again, this like fear that maybe ties into like the economic uncertainty that's happening too, is like, if I just keep myself and my things clean and I prevent transmission, then I can be one of those people that goes back earlier, right? And it's a lot of things.
All right, so this is embarrassing to admit, but I used to compulsively wash my hands, and one of the ways that I backed that was when there was the whole reaction against antibacterials, saying, you're destroying the microbiome on your skin, you're actually creating disease by over cleaning and over cleansing. And I was like, I need to, and soap irritates my skin. So I was like, water is enough most of the time. And now I'm like, I would give anything to have those old, slightly OCD habits that I used to.
Since you admitted it, I will admit too that I actually, as a young child, had pretty classic pediatric OCD with hand washing. And like back in the 90s, they were just like, they took me to my pediatrician, and the pediatrician was like, "Don't wash your hands. It's fine. You're not going to die." And like that was my treatment. And so like as a very young child, I was taught to like not fear germs, and that's how they like broke me of my OCD. And like I have really bad hand hygiene, and I've had to like develop new patterns. I wasn't going to say it, but since like one of the most respected Victorianists in the field said it, I can get away with it.
Like I always say, like I'm a very bad public health professional. Like, I mean, I wash my hands, and like especially during like cold and flu season, I'll do like the full alphabet wash and things like that. And like because it's like super effective, right? It's low intensity, super effective. But I don't wash like my groceries from the grocery store. Like I'll rinse the apple the same way I used to before. I don't wash down the bags. I'll wash my hands after I come in. I'll like wipe down my phone and stuff like that. But I'm not one of the people that's doing the obsessive, like, I'm going to leave this box out in the sun. I mean, I also live in Brooklyn, so I can't. I'm not leaving my box out in the sun for like 3 days to like be exposed. And like, I think it'll be okay. Like, I'm trying not to touch my face. Wearing the makeup that I wear is protective because I've trained myself. Like, if you touch your face, you're going to mess up your mascara.
It's true. I'm putting on so much more eye makeup now.
Right?
On the other
so I was like pretty good about that. But yeah, it's like one of those things. I'm not following the like super strict, or I'm not allowing myself to go that way, because it's like, basic hand washing is fine. Just like, if you break down the fatty layer around the virus, it's gonna just like be exposed to the air, and then it'll die, be fine. And so far it's worked, but I also could just be a disease, who knows.
Yeah, I think it would be different if perhaps if when we're in the epicenter, if you were in Manhattan right now and you're sharing a building with hundreds of people and you know that there's a lot of infection around you, you might be thinking, gosh, the amount of viral load around here might make you more cautious of those things.
Well, and like when I use the elevator in my building to like go out, or I use the commute, because I live in a big apartment, big-ish apartment building, I like tuck my hand up in it. And like I've also been trained as like I used to do like HIV counseling and testing, so I'm also like very trained about like how to wear gloves, how to take them off, how to open doors like with your elbows, so you didn't have to clean up again. So it's one of those things that's like, oh, this comes in handy. But yeah, I mean, like, yeah, I think like now, how many people are touching that elevator button? Like,
yeah, absolutely. The whole like geography of what is pure and polluted, to use that sort of classic opposition, has really changed. And what I used to think of as just either neutral or maybe dirty but not in a scary way is now like I recoil from it.
Yeah. I mean, I've been taking the subway since like well before March 13th. Because my job, like they were pretty quickly like, no, we're going to like online teaching. And it's like, oh, okay. Like I can't imagine like touching like a subway pole or anything. I'm like, oh.
I'm never gonna, I go to London pretty regularly for research, and I know Pamela, you do too. And like, so that's where I get most of my public transport experience. And I don't think about germs that much. Like I'm not scared of them.
Yeah.
But now I'm like, I'm never going to think of the subway the same way ever.
Well, think of all the essential workers in New York who are getting on that subway in Queens and running 40 minutes to get to work. And they don't have a choice.
Yeah,
it is what it is. But I mean, I've seen pictures and, just like 50 people in a car, like strap hanging.
Oh, 50 people would be so few people. It would feel like,
well, I'm guessing.
I always make the joke, like, in New York, we come into contact with people very differently. As like, somebody's hanging onto the strap and like you're tucked up into their armpit, and like, you're just excited that you got on the train and didn't have to wait for the next one. So like our idea of personal space is very different.
Yeah. We've altered that sense of space for those spaces, right?
Yeah.
I mean, I remember traveling in Japan many, many years ago, and they really did like push you. When you couldn't get yourself any further in, they would pack you in to get you on the train. And, I mean, you would never be that close to a stranger on the street.
Ever, yeah.
But it's sort of like when you're in an elevator and everybody just faces forward and pretends they're not 6 inches away from each other. It's it's the etiquette of the space.
It'll be interesting to see how it changes public spaces like that. Cause like a lot of my research is in France, so I'm in Paris a lot. So a lot of the metro there is fabric covers for their seats. I know it's the same way in the tube as well. And it's just like, I always kind of thought it was kind of gross, but now I think after this I'm gonna be like, oh, in New York, it was like the hard plastic that you could wipe down and sanitize. But yeah.
Yeah, I hadn't even thought of that.
Oh,
okay. Last thoughts. We're at 45 minutes, which, by the way, it's our 1 month anniversary of COVID Convo.
Wow, we've been quarantined for a while.
Yeah.
That's both wonderful and sad. We all took a minute to take that in.
Yeah. Well, we're all still here, so
yeah,
that's something to celebrate.
It is I thought of how you said that last week, like a grounding point to my week, where like I said, I loved the first 4 weeks of quarantine. Like I was happier than I've been in a long time. And then like right at week 4, I was like, I have organized what there is to organize. I have written the things I have to write. And so it was nice. It's been nice this week to be like, okay, it's Thursday. Like I made it here. It marks the week. Chat with some people in my field, and
I'm concerned about how it's going to feel like over the summer. I mean, we're still going to be doing some kind of social distancing, I think.
Yeah.
Like what's it going to feel like over the summer, like when you want to be out and you want to be social because the weather is so beautiful, and then if there is a second wave in the fall, like.
Yeah, I think that really hit me today. That was just thinking, wow, this is going to be a while. Like I have to stop thinking in the temporary and start thinking more long term. And
I'm trying not to think about it being that way in the fall. I call that my dark line timeline.
Yeah, my students were just talking about that in our last class meeting. They were feeling really stressed about the idea of us potentially not going back to campus in the fall if it happens. And
mine asks me every single session, like, have you heard anything? And I was like, no. I was like, often they send you the emails and then they'll send us the email that's like, oh, by the way. So I was like, no, I was like, and you hear all the interesting rumors. So like, what are you
hearing? Yeah, I love how they think like the professors are like privileged employees. They get tons of information about how the university works.
Yeah, it's true. I often learn how the university, what decision they've made by reading the local paper. I get that before I get a memo from the university. The alligator is reporting.
That's how we all at Kent State found out that we were going to online classes.
Oh my God.
Oh, wow.
Wow.
Though I think that was a mistake, an accidental pressing of publish before they were ready to. I think they meant to let us know first.
Good. I hope so.
Yeah.
Yeah, that's what they told us the first time. And then by the second time I was like, you keep making that
an error. All right, guys, I should turn this off so that, as I say, y'all will keep doing this and not feel like it was too exhausting. Mary Beth, you are welcome back any week.
Yeah, I always nothing on my Thursday, and this was very lovely. So if you'll have me,
lovely to meet you.
Yeah, we'd love to have you any week. It's always this time on Thursdays. I just shoot the link. I'll add you to our group chat if you want, so that's where I put the link up.
Lovely. Yeah, it was so lovely to meet new people.
Good to see you guys.
Nice to meet you too.
Bye.
Thanks again for joining us for this episode of the Human Capital Innovations Podcast. I hope you stay healthy and safe and that you have a great week.